Those employers have every reason to want a strong, healthy healthcare provider community, but they also don't want to overpay. And so bringing those folks together in a conversation that might result in a direct contract is really what I know, Shane, you've tried to do for a long time in a couple of different markets. It's challenging though, right? To get people to think outside.
I believe
the network
employers
box.
should create an employer-owned group purchasing organization in every major city in the country and negotiate the rates themselves. But you have to be big.
Welcome to part 2 of our conversation with our guests today about direct contracting and other types of tangential topics around the cost of healthcare, what we can do to solve that problem, that riddle that plagues all of us here in America. Thank you so much for being here. If you did not listen to part 1, you have to go back. Okay, if you don't listen to part 1, part 2 won't make any sense. So make sure that you go back and catch the first episode of this series of our podcasts, and we'll jump right in.
So yeah, there's two major metropolitan areas in Oklahoma, for instance, Oklahoma City and Tulsa, and healthcare prices in general are about 10% higher in Tulsa than they are in Oklahoma City. And we have one very dominant hospital in Tulsa that it's kind of the go-to place. They've got a great reputation, but they also are very opportunistic, and they take that and they leverage that into overall higher prices. And the other hospitals, as opposed to lowering their prices to try to pull that away, they raise their prices because it's now the prevailing rate. And my recommendation for those folks is you should drive to Oklahoma City to buy healthcare. So
we actually contract with one of the first companies that started pulling together the transparency data, a company called Turquoise Health. And they had a study here this last year that looked at, what's the impact of the transparency law? Has it done what you said, Shane, bring down the high cost people, or is it like maybe we said, just bring up the low cost people? They actually showed that it did a little bit of both nationally. I don't know how that works in a two system town, because you can't really do both, or maybe both sort of meet in the middle. I think that's over time. That's essentially what happens, but which one goes first? Guarantee you, the low cost or the low reimbursement hospital health system, immediately when they see that data, they're in with Blue Cross negotiating a higher rate. And so they'll push harder than the high cost or highly reimbursed system will be in there offering up any money. So I think over time, you'll see this convergence, probably a little bit lower for the high and a little bit higher for the low, meeting in the middle. But Turquoise's view of it was a little bit of both, probably a little more of the high coming down, like you said, Shane. So I don't know, but in a macro sense, in a single market, it's probably a little bit of both. I've seen it actually in some of the markets where the ceiling became the floor, right?
Sure.
The low came up to where the high were in the reimbursement. But jury's still out on the transparency law. Like, I honestly don't think, certainly consumers can't look at the data and make heads or tails of it. I think that's next to not happening.
that's what our job's for.
So those of us that are dealing in this stuff, trying to just decipher it. Now we're also dealing with a little bit of non-compliance, non-reporting, or incorrect reporting, both by health plans and providers, and so some of that's a little hard to really pin down. But you can on some systems they've done a really good job of posting the data. So. Mm-hmm.
So I'd like to step into your areas of expertise in a way I probably shouldn't. But if you take the market you just described, I would ask, have the self-funded employers in that city sat down in a room? Do they all understand someone's at 200, someone's at 180? Have they collectively or individually, but concurrently, gone to their insurance provider and said, design my benefit structure that creates tier 1 for the 180 and tier 2 for the 200 now? So we will let our members go where they need to go for care, but they will have very clear, simple benefit plan structure that incentivizes them to go to the more efficient provider. And what I don't see happening in markets is that, because, does the bottom come up? Does the top come down? It's in the hands of the employers. And I don't mean that they're not doing what they should do, but they'll have to behave differently as customers. It's not the patients. It's the employers who have the knowledge and the ability to advocate and create that benefit plan structure that says, oh, I'm going to go here for my MRI instead of there because I don't want to pay a $500 out of pocket. I'll pay the $20 at the tier 1 provider. But if you do that, now I'm competing on price in the market, and I do not see markets that I know of organizing themselves in a way to say, we will reward the high value, high quality provider by moving people with their feet through benefit plan design that's simple and effective.
And I think the challenge with that, because there are, for example, in Indiana, we have the Employers Forum. There are forums designed for this type of conversation. But I think the challenge with that, Shane, is that the broker community, the advisement that these employers are getting is financially biased, because a lot of brokers are being paid overrides by insurance companies that comply and are complicit in the way the status quo. But 2, I don't think that there's enough sheer technical knowledge in the broker community, that to allow for that type of conversation, because I think you're right. I think if there were a collective conversation around, here's 220% of Medicare, that's tier 2, here's 180, that's tier 1. And by the way, your deductible is waived if you go to hospital Z, that's 150. That would be progressive.
And if the health plan won't do it, switch health plans. I mean,
Switch brokers.
The customer has to drive the behavior, as in
Absolutely.
any industry, in my view.
Yep.
Those kind of health plans are actually very common in the southern, southwest area of the country. Texas and Oklahoma, that's what you see with progressive consultants and third-party administrators, and that's what employers are really demanding these days. I'll tell you what the impediment, though, is to your comment about, why is this happening? Why aren't these plan designs out there? And it all has to do with the network contracts. The large carriers within their contracts, they have, even if it's a large carrier is renting their network, these contractual restrictions they follow, and that is their non-steerage, non-navigation provisions within those contracts. And if you're not going to have those contracts, you say, well, fine, I'll just do without them. Well, in that situation, then you're looking at going reference-based pricing. And it comes with its own baggage as well. So it's more of a path of least resistance. But the carriers will not build a plan design like that because their large health systems won't allow them to. And unfortunately, the consulting community tends to go where the big carriers go because that's who they look to
That's
for
where they're getting
compensation.
paid. Yep.
Yep.
Well, and that's partly because of the safety blanket that's the network.
That's right.
That employers, they really struggle when they have a patient that comes and says, well, I'm having, who's in my network? And you say, well, you can go wherever you want to go. Let us help you get access. And access is the more important element than a contract. Contract can be a means to access, but we really preach, let's figure out how to access the system in any way, shape, or form that the system will engage with us. And some providers are a little more challenging in that respect, but not all employers are ready to have those difficult conversations within their employees and their families.
Very few employers are ready to take a stand. They'll complain at renewal time.
Yep.
But it's a big step.
But this is where I think, and goes back to the direct contract, this is where, Shane, to your point, bringing together a group of employers in a community, sitting down with the hospitals and the health systems in those communities directly and having that conversation of, here's what we're going to do, here's what we need you to do, we want to work with you. They certainly, those employers have every reason to want a strong, healthy healthcare provider community, but they also don't want to overpay. And so bringing those folks together in a conversation that might result in a direct contract is really what I know, Shane, you've tried to do for a long time in a couple of different markets. It's challenging, though, right, to get people to think outside.
I believe
the network
employers
box.
should create an employer-owned group purchasing organization in every major city in the country and negotiate the rates themselves. But you have to be big. And the only people that the health plans and the health systems will listen to at the end of the day are the corporations, that are sponsoring the insurance, is my belief. But having every HR department and every major company try and figure this out is really hard.
Yeah.
And that's what some default to. They try, but it's too complex, it's too big, and there's really no reason in my mind they have to take it on their own. And I don't think that every broker and benefit advisor understands the data even well enough to give always good advice. I've seen bad advice myself, and it's hard for an employer to discern who's really giving great advice and who isn't. How would they know?
Right. I mean,
And
how
so
do I
it's
know?
Very
Yeah.
hard. It's very complicated for them to figure that out.
Yeah. I mean, you could go to 3 different doctors for the same ailment and get 3 different outcomes, right? You 3 different prescriptions or 3 different,
Treatment plans.
courses of action. And how would you know as a layperson who doesn't have a medical doctor, right? You wouldn't. You just hope that your doctor's doing the right thing. I also think it's really frustrating, going back to what you're talking about with the network. I think what's really frustrating from sitting in a former advisor seat myself, I did a lot of reference-based pricing, and the thing that was tough as an advisor is that the employer is mad because they're paying so much money year after year with an Anthem or United Healthcare in my Indiana market, but they don't want to lose the logo. They don't want to lose the brand awareness of the network, but that's literally what's screwing them.
Yeah.
But they can't get rid of that affinity for the brand in exchange for a better, a better outcome, a better opportunity for cost savings.
I mean, we all know people that are proud to stomp out of a car dealership over $50 on, trying
Sure.
to negotiate a vehicle.
Yep.
They wear it like a badge of honor that they're a good shopper. But most employers are unwilling to do those things because it's not just the employer. The employer would have to actually. They feel like, well, I'm affecting my employee's family and their personal life. I have a client that kind of pounded the boardroom table one day during a renewal after he learned that one of his employees bought, I think it was a knee replacement from a rural hospital and paid almost $190,000 for a knee replacement. And then when he found out what the real price, the market price was for it, he just said, "That's it. We're no longer giving these employees a blank check. They're spending our company's dollars and their own dollars so unwisely." And I mean, that's what has to snap within the C-suite, that they're going to have to start looking at healthcare like everything else that they look at within their organization. And there's just not a lot of employers that are willing and ready to do that.
Because it's painful, right?
It
For
is.
years, every renewal, they've been burned, right? And so when you bring in the hot plate, and you're like,
Well, they've also
hey,
been told the lie, which healthcare is different and healthcare is too complex and it can't be managed. Again, that's the seller's problem. If it's too complex and too difficult to manage, you need to find a seller, medical provider, that is going to help you. Mm-hmm. It's very hard to right now, but
Sure.
that's those are the market forces that have to be in place.
The Wellbridges of the world
I'm
and-
not going to buy from you because you make buying from you too difficult, and I can't discern your value because you're opaque.
right,
It's going to cost you my business.
right.
I have struggled with, maybe you can help me with this. I've had the opportunity to sit in on a few occasions with employers while they're listening to their broker and or benefit advisor on what to do for next year's plan. And the couple, so it's not that I'm expert in it, but I've seen a few of them. And in general, so I'm sitting at the table with a self-funded employer. A really nice slide deck walks into the room. It's got a ton of data. It's kind of overwhelming. And at the end of it, it distilled down to your cost per member for next year looks like this number. And in one of those conversations, the people left, they finished the presentation. The CEO and CFO of that company, after the team had left, said, well, even while they were still there, said, we can't afford that level of increase next year. Like they showed this year versus next year, what they thought it'd be. And it dissolved a little bit into an angry conversation, a frustrated conversation. And people left. then, and so we were sitting in the room a short while afterward, and we were talking about it, and I said, what I don't understand is you're a self-funded company. So your advisors just came in and said, next year the cost per member is going to be this. And you said that's too high. And they said, well, let us go sharpen our pencils. We'll come back. Let's talk in a few weeks, whatever. They're going to have a second conversation. I said, I think they're going to come back with a lower number. And I assume they'll come into the room and say, I wasn't there for the next one. I said, I assume they'll say, when you asked us what we could do to bring the cost down, we told you we didn't know. But we went back, we put our team on it, we worked really hard, we sharpened our pencils, and they'll give you a new number. But what I don't understand is neither of those numbers are real. Your self-funded plan, your cost will be whatever your cost is for next year. Somebody can give you a projection, but that number is just an estimate. If you want me to change my estimate, just give me 5 minutes. I'll come back with a new estimate for next year. And you sign up and you move on. And I said to them, if I were you, and I'm sure nobody would do this for you, but I would say to my provider, give me a de-identified list of all the services we paid for last year for healthcare and tell me what I would have paid as a bundle or a bucket with insurer number 1, insurer number 2, insurer number 3, or health system number 1, health system number 2, health system number 3, and actually see what your total cost differential would have been for the same volumes run across the same payment codes. And I don't know if that ever happens or not, I guess, but to me, that's, if you found out one health system was 30% more expensive for the bundle that you purchased last year, that's probably directionally good enough to figure out maybe they should be your tier 1, the high value, lower deductible network. And again, I'm not big on excluding other providers, but put them in your more expensive, the patients can go there if the right doctor, the right treatment plan is there, but just
they have that specific specialist or whatever.
And make it simple, because the patient who chose 190,000 knee had no way to know. They just don't know that.
They just went where their doctor told them.
Yeah.
Yeah, and between charges and prices, you can't, and I also say once people get sick or a doctor says, I want to run a few more tests, I don't look to the individual consumer to shop for much.
Right.
It needs to be done way in advance through the benefit design.
That particular employer did have exactly what you're describing, the tier 1 option that would have been no cost to the patient. But
whether it was enough or not, I don't know.
It was not enough because the patient looked at it, they were going to meet their out-of-pocket no matter what.
And maybe you have some places that you say, look, you're not going to go to this hospital for non-emergency services. I don't know, but those are excruciating examples where it's silly that somebody paid that much for that service and had to.
Yeah, and that actually touches on even, as bad as the variability is in what's paid for healthcare, what's actually charged for healthcare is even worse in terms of variability. And you look around the country, there's absolutely no good explanation for why that would be. And to the extent that somebody would negotiate a contract that's tied to that charge, that's just asking for trouble. That's a
percent off billed charge, essentially.
Any sort of discount off charge or charge-based reimbursement for the lion's share of the care is something that the providers all want to insist on. Some of the administrative, pricers, or when the insurance company acts as the ASO, it doesn't really matter to them that they're tying it to some sort of a
That's part of the deal.
nebulous number.
Yeah. That's part of the deal, right? So
yeah.
they don't have a real incentive in order to switch it from a charge-based discount to something that's more, tied to a reference point.
We see that all the time as well. The interesting thing is they'll always say, well, Medicare is flawed. It doesn't pay anesthesia enough or whatever else, so we don't want to use that. But it gets back to your comments. We're not saying Medicare gets it right. In fact, I'll tell you Medicare gets it wrong most of the time.
But we need a common language.
But it's the common language.
Yeah.
You bet.
Yeah. I have some providers that I've talked to, and we want to have a good relationship with providers. We'll negotiate like heck. But when I walk in and they say, nope, we don't do reference-based pricing, and I'm thinking to myself,
You mean you don't take Medicare?
right.
why would
you
that?
cash the government's check, right?
We can argue about the multiple. Let's talk about the multiple, but at least now we're talking a common language on what it is we're going to pay for and how we're going to allow you to bill for it, and all those things are sort of complicated as they are. They're all decided.
And we can even discuss, what what fiscal year Medicare we're talking about.
Absolutely.
If I was a medical provider, I'd be worried about what those maniacs in DC are going to do to
Sure,
me next year.
sure.
But that can be written into the
Yeah,
contract.
yeah. We could hold it, fix it
2024
fix a year
or-
and,
yep.
and leave it there so next year, if we do it, we increase it by 3%, you're going to get a 3% increase. But
Bottom line is percentage off billed is just so lucrative, and
Yeah.
it puts the pen in their hand, and they don't want to give that up.
yeah, yeah. And a big part of the system, not beyond just the providers, actually has an incentive just to leave it that way.
Yeah.
Yeah.
From my perspective, when I get in the conversation as a hospital, a health system CEO, and we talk about our fees and charges, I don't think about it or talk about it that often. But when I've said, do we still have people paying percentage charges? And somebody from the contracting team says, yes, some, not many, but some. In my head, I'm like, I have no idea why they would do that.
Right.
But there are some who have not.
A lot of times, the hospital, that's all they'll offer you.
If you're trying to get into a direct contracting situation, you're saying?
Yeah. If you're a lowly community employer, then that's all you'll get offered. If you're a large carrier, you'll get offered the better contracts.
Yeah. Per diems.
If you're in a small town, I would call the board member who's owns a company in the community and bring it up. I mean, there's no reason to pay a percentage charges. The charges mean nothing. I'd love to see our industry just completely abandon it, move away from it.
I like you.
Thanks.
Yeah. We're gonna snip. I'm gonna snip
Friendships are
that
formed
piece of the
here.
I think we
podcast.
need to separate the two of them.
Yeah, yeah, you guys need to
Too
switch
much
apart a
agreement
little
between-
bit.
yeah.
So I was going to ask you earlier, does every hospital system in your experience understand what reference-based pricing is?
No.
Okay.
No, I think in some areas where it's been a little more prevalent,
Like Indiana, for example.
Indiana, and some providers, it's a dirty word. I mean,
Sure.
we spend a fair amount of time explaining how we're not like that, because there have been some in our area that maybe have really taken more of a scorched earth sort of strategy. But in and of itself, when you sit down and you can have a conversation with a provider to explain, okay, we're just talking about a pricing mechanism. That's really all it is when you say reference-based pricing. Now, there's a lot of things that will fold into that. Usually you can get the guard down a little bit to have a conversation. It doesn't mean you always get an agreement, but
Sure.
you'll at least have a situation where you're not getting food thrown at you. So
Sure.
but those are the conversations, frankly, it's always better if we can walk into that conversation partnered up with a local employer that's looking at a different solution and say, hey, we're going to come as a co-fiduciary. So we're really speaking on behalf of the client or of the plan and ultimately of the members in that plan. We want to have a conversation about the pricing mechanism that we're going to use, and let's negotiate again in the common language.
Yeah, and that kind of goes back to the point Shane's made a couple times, which is that the larger employers in those communities really hold the keys in terms of driving that conversation.
But if the employer is not willing to go the distance with it and really sort of put the shoulder to the wheel on that conversation, you get to the point where maybe one side's going to call the bluff of the other, right?
Sure.
And I think some employers are getting to the point now where they simply can't afford what's happening to them in the traditional world, and so they're the ones willing to take that on, that difficult fight on. It's difficult and complicated to get there, but it should be easier at the end of the day to
getting
compare
easier.
things. Yeah. Yeah.
One more thing I wanted us to make sure that we got a second to touch on. We talked earlier about the main components of a direct contract. One of them we talked about was getting the price right, and we just touched on that a little bit more. It's not ideally we're not taking a percentage off a bill charge. Ideally, we're using the Medicare language to create common understanding of pricing. Do you want to talk a little bit about audit provisions, audit rights?
Sure. Yeah, one of the things that we always try to do is get what we call audit rights, but really it's a review of the itemized bill and the ability to go back and get records to make sure that everything on the price sheet that we're pricing are things that should be paid for once but not twice. And so what do I mean by that? Well, there are a lot of things that sort of when you do a case or you do a surgery, there are a lot of components to that are bundled into the CPT code or the DRG if it's an inpatient stay. And those things are oftentimes itemized out on a bill, but shouldn't, and are priced. So there's a charge that goes with each code, but they're also tied to the controlling code or DRG that would be out there. And so one of the things that I do, and I've been negotiating these types of contracts for a long time, more years than I care to remember. But I find myself often going back to our team of coders and auditors saying, as I'm negotiating some language or putting some provisions in the agreement that are requested by the hospital or the health system, going back to them to make sure that we can still do what we need to do with these sorts of changes. And candidly, I couldn't do it without our team behind us having those conversations because of the complexity and the knowledge that you need to have in terms of all of the different coding techniques and rules that are out there. And so again, that's also a shout out to the Medicare reference. So Medicare has some standard ways of handling multiple procedure codes, for example, or if they're doing a shoulder, they might have 6 or 7 codes that they actually implicate. How do you treat each one? Do you treat each one as fully priced, or do you start reducing each subsequent code after the main code? And some of those things have to be, you have to know how they work and have that expertise behind you when you negotiate these agreements. Otherwise, you're going to end up with a contract that really sort of creates more problems than it solves.
And solutions.
So that's a sort of a long answer to your
Yeah.
short, simple question. But having a team behind you is essential if you're going to do that. I don't know if your experience is the same.
No, it absolutely is.
Yeah.
I mean, that stuff gets into the weeds really fast and really deep. So yeah, having those provisions either in the plan and the plan being referenced in the agreement or explicitly referencing audit rights in the agreement is key. One other thing that on direct agreements that I don't know that we've really talked about is we continue to see, and unfortunately a lot of times it's the consultants that if they get involved in direct contracting, it's like lambs to the slaughter, unfortunately.
Yep,
But
I've been subject to it myself. Yep.
they may have negotiated a pretty good deal with a hospital, but they've forgotten all of the things that are going to go into that episode of care that are not billed by the hospital, that are billed by a third party. And those are just not addressed at all. And so you really don't have a comprehensive agreement at all. And the parts that are not billed by the hospital are generally the ones where that's where a lot of expense hides. Things like intraoperative monitoring or emergency department or whatever, imaging. There's just any number of things. And so, there's a lot of, this is more complex than it looks.
I was working with a plan that also happened to be a provider, and so they knew very well. They understood lots of the coding issues, but they didn't understand everything over on a different part of the healthcare system. And so they negotiated this agreement. We offered to help them review that and give them feedback. They declined because of the discussion with the local health system, and after the fact, it turned into a lot of cleanup on aisle 3, dealing with some of the issues that were either silent or just frankly probably not in their best interest. And we could have helped them out a lot on the front end of that. We managed to find our way through it, but that's part of the challenge. If you don't, you can look at it. It might be a 10-page agreement with lots of familiar provisions that most lawyers can read and understand, but there's a lot of stuff buried in the healthcare specific provisions in that agreement.
And some of those providers that are not billed under the hospital are the most antisocial
Yes.
there
Yes,
is.
yes.
So I can see why the hospital did want to deal with them.
Yes.
But they're the ones that hired them, so it was their responsibility. They've just abdicated their
Their cross to bear.
responsibility.
And Shane and I can both attest that sometimes the ones you work with when you're a hospital administrator that you sort of understand how difficult it is to negotiate, but necessary evil.
I've gone to a hospital before and said, well, I know you told me that anesthesiology is very difficult for you to negotiate with, and then that's not going to be part of the agreement. Is there I always say, well, so I can bring my own anesthesiologist group to your hospital. I'm like, no, of course you can't do that. It's like, well, but I thought you said you had nothing to do with them.
Yeah.
Well, we do pick them. It's like, oh, then they are your subcontractor. And so why do you just get to punt on negotiating with them? I mean, it's not like it's an optional thing for a surgery. And so, yeah, those are always interesting.
Well, and
conversations.
in fairness, and Shane can talk more about this, but in fairness, the way hospitals are set up, they don't always necessarily pick the anesthesia provider. That's really a privileging and a credentialing function that happens separately with the medical staff. And so the administrator sometimes might have a strong opinion, but that gets trumped by the medical staff. And so,
Which are also employees.
not always.
No, not always. So it's not
Oftentimes
as
they're-
it gets to be complex, but there's obviously still independent providers, and
Yep.
when they're independent, they have privileges. If they have privileges, they practice. It takes the process to bring somebody else on to privileging. So there's some. Goes back to the complexity of the industry again. It takes you down a whole different road though too of the entry of private equity and scooping up some of these groups, and there's a whole nother conversation that's probably a different podcast, but
Sure.
Yeah.
that creates other complexities and challenges in terms of providing value-based care. But there's no reason we shouldn't be striving toward comprehensive contracts. I mean, my view is that healthcare is, I don't care if you overpay for a car or a cup of coffee, or, you do whatever you want. But there's a moral side to this that as an industry, we have an obligation to have honest conversations and do our best to make our amazing healthcare system affordable and accessible for everyone in this country. And there's just a lot that can be done to do that. This is a part of it, but it's one piece. So
Yeah, that's really insightful. Well, Shane, Jay, Brad, as always, thank you so much for being here. We so
Thank you.
appreciate your knowledge and taking the time to come visit with us. If you have not already, you need to subscribe to the podcast wherever you're listening, YouTube, Apple, Spotify. Make sure that you're subscribed. Like this podcast if you learned something new. I know I certainly did. Thanks again for being here, and we'll see you next time.